A brief round of introductions. So I'll go first. I'm Chloe, the UK trial manager, and then I work closely with Leah.
Hi, I'm Leah, and I'm the Deputy Coordinator at the Bristol Trial Centre.
Thank you. And then Mark.
Hi there, Mark Edwards, Prof of Anaesthesia in Southampton, leading LOLIPOP in the UK.
Thank you. And then I'll just go around in order on my screen. So Angela. Oh, I can't hear you. Is that just me? Oh, there we go.
I'm Angela. I'm one of the cancer research nurses that'll be working on the trial. Thanks.
Thank you. Jodie.
Hi, I'm Jodie Kirk. I'm one of the clinical trial pharmacists.
Thank you. Gafar.
Hi everyone. Hi. I'm one of the pharmacy technician clinical trials. I'll be supporting Jodie in these clinical trials.
Great, thank you. Tamara.
Yeah, hi, I'm Tamkin, and I'm the PI for this site. I am consultant breast surgeon.
Thank you. And Vina.
I'm an anaesthetist in Wiston Hospital, and I'm the associate PI for this trial from anaesthetics.
Great, thank you. I'll share the slides and we shall get going. Yeah, sorry, just before we get going, just to say that the slides are kind of a summary based on the assumption you've watched the training video. So if anything, if you would like more detail on anything, or you've got any questions about anything, please do stop us as we go through. Because yes, some things might be a bit brief, but we're happy to sort of elaborate if you need it. So I'll hand over to Mark then.
Great stuff, thanks Chloe. So morning everyone. Feels like we were talking just quite recently for your feasibility call, and I saw a few faces at the investigator meeting on Wednesday. So good to see you all again. So this is your official site initiation visit for LOLIPOP. Just to give you a bit of background on the trial, this is not something that we sort of originated ourselves. We were approached by an Australasian team that we work with, linked to the Australia-New Zealand College of Anaesthetists Clinical Trials Network, who'd started this trial a year or two previously in Australasia after a very successful pilot trial, and was seeking help with recruitment, but also trying to harness an opportunity to bring UK-specific data into the trial. So it's funded in the UK by the NIHR, sponsored by my employing organisation, Southampton, and very well supported by the Bristol's Trial Centre. So next slide just gives a little bit of the sort of overall aim of the trial. So we're looking at patients undergoing primary breast cancer surgery, and we're looking to see if IV lidocaine can reduce chronic post-surgical pain at 1 year after surgery as compared with a placebo. I'll just rattle through this because I think we covered a lot of it in the feasibility call, but the rationale for this that we go through on the next slide, I think, is that we are interested in reducing chronic post-surgical pain, which is a major issue, increasingly recognised as a problem after surgery, and also particularly in breast cancer surgery, probably has an incidence of up to about 50% of women going through this surgery, so a really common problem. So covering the inclusions and exclusions. Inclusions are very broad, so any adult female patient undergoing either unilateral or bilateral surgery for primary excision of a confirmed or suspected breast cancer under a general anaesthetic. They can be having simple implant or expander procedures at the time of their operation. That's fine, as long as everything is in a single stage operation. And in terms of the safety of the infusion, there are a few things both in the inclusions and exclusions to make sure that we're not giving this infusion to patients that have got a lot of comorbidity. So they need to be ASA class of 1 to 3. And in the exclusions, there are a number of things, both cardiac, electrolyte, other medications that interfere with it, you'll see that would exclude them from the trial. We're finding that not a lot of patients have got those exclusion criteria. Some are on beta blockers, which is one of the drugs that interferes with the metabolism. So we lose a few for beta blockade. And the occasional sort of slightly funny ECG. The important thing with the exclusions is that you don't need to do any additional screening just for the trial. So patients should just go through their normal clinical pre-op assessment, and you should base your decisions on exclusions just on that clinical information. The other thing that would exclude patients is if there's anything that's going to confound the results. So if we know for definite they are going to be having a second operation in the follow-up period. So if there's a firm plan for a slightly larger reconstruction operation, or if this is repeat surgery in the first place, then we don't include these patients. And if they've got specific pain either around the chest wall or the axilla at the site of surgery, again, that could be a confounder. So we don't include those patients either. There's a full list of all this in the protocol. Okay, next slide, please. Just before I go on to the sort of the flow through the trial, are there any questions on inclusions, exclusions at all? Obviously, we did go into some detail on some of the surgical aspects of this on Wednesday, which I thought was very useful. Okay, great. Okay, so I'll move on. Now, refreshing my memory, am I right in thinking that you're a site that does vast majority day case and that your plan is just to target day case patients only? Is that right?
Absolutely, yes.
Fine. Okay, good stuff. So that is similar to the vast majority of our recruiting sites so far. Screening and eligibility, we'll talk about your individual pathway. As we said before, the protocol is quite broadly written to allow this to fit in around normal clinical pathways, basically. We do encourage, wherever possible, surgeons to be involved at an early stage and to at least mention the trial. You can use posters in the clinic rooms, that sort of thing, and it just puts it on the radar for patients and hopefully increases the chances of them saying yes. A lot of the screening we then do is our research nurses looking at confirmed theatre lists, so at least we know when and where a patient is coming through, and then some contact with some patient information, an opportunity to review that before the day of surgery and to come back and ask any questions about it. They can then sign the consent on the day of surgery, or they can be sent it out in the posts beforehand if you want to get that squared away. Of course, if they're coming in for pre-assessment, that's quite a good opportunity to see them face to face if you want to use that as an alternative contact point. Randomization should happen on the day of surgery. The idea is we want to prevent cases where they're postponed, and we definitely want to avoid opening the trial drug until we know that surgery is definitely going ahead, because that would actually lose the patient to the trial. In terms of data, once they've been randomized or once they're sort of consented, there's some baseline data, some quality of life stuff, pain scores, that sort of thing. The intraoperative infusion is then prepared. We'll go into that in a bit more depth. It's administered during the anaesthetic, started after the patient is asleep and with their airway secured. Given through an automated pump, gives a bolus and then rolls on to a lower rate infusion, and that carries on through surgery and into the post-anaesthetic care unit or recovery unit with some ECG monitoring. And then the patient should leave recovery when they are clinically ready. That's often quite quickly after breast cancer surgery. We know that they're usually pretty fresh after anaesthetic, so if they're ready to go out of recovery after 20 minutes, 30 minutes, that's absolutely fine. You stop the infusion, and away they go. The maximum time it should be running for in recovery afterwards is an hour. If for some reason they are there that little bit longer. There's some intraoperative data, as we heard on Wednesday. A great time to collect that is in the recovery unit, just so that the anaesthetist and the surgeon are available if you've got any queries or you can't read their handwriting. And then the patient is also being monitored for any early signs of local anaesthetic toxicity with the list screen that we'll go through in a little while as well. And then there's some post-op data collection at the point of discharge. And then once the patient is discharged, we've tried to minimize the amount of follow-up that you have to do from your own site. So if it's anything that is patient-centered, and there's some of this stuff at 3, 6, and 12 months, anything patient-centered, we will automatically contact the patient with an email or phone alert and ask them to log on to an online database, and they can put in their own patient-reported outcomes at that point. So the only ones you'll hear about are the ones that have not responded to us chasing them up, and we'll ask you then to phone them. But you don't need to track down patients and go through long questionnaires with them on the phone during the follow-up period, which is good. There are a couple of data points that will need a brief notes review just to see what further treatments they have had. But hopefully it's pretty light touch and straightforward for the follow-up phase, and actually the day of surgery, we find things run pretty smoothly and it's pretty straightforward. Any questions on what we've talked about so far, or the sort of the trial overview training module that you've hopefully had a look at? Any comments or questions on that so far? No. Good stuff. I think it's all very fresh in people's minds, which is great. Okay, I'll hand over for a trial update.
Thanks, Mark. So yeah, you had a bit of an update at the investigators meeting, so I won't go into too much detail, but just to say that the trial is open across Australia, New Zealand and Hong Kong. There's 980 patients recruited so far, and 42 of those as of yesterday are from the UK. So next, we're going to have a bit of a discussion. I can't see anyone, so please just shout out as we go through these. So as I mentioned, these questions are sort of based on the assumption that you've watched the screening and consenting and randomization training videos. So we just, wanted to have a sort of discussion with you about sort of how do you see Lollipop working at your site? So who will identify patients and be approaching them at your site? I can't see again, so just shout out.
Sorry, Mandy's just gone off my screen, so I'm not sure whether she's dipped out of the meeting, but we were going to identify the patients from the theatre lists. So the research nurses have access to all our theatre lists and we'll screen them from there. And then we'll be approaching them, the research team.
Great, thank you. And then could you run through your plan for the day of surgery? And obviously randomization has to take place on the day of surgery, so have you thought about sort of the logistics around that? Obviously it's quite a busy time.
Yeah, so it is a busy time. Obviously we're going to see them first off on the ward and confirm consent, make sure all that baseline stuff's done. We have a surgical team huddle at 8:20. That includes all the recovery staff, so we're going to attend that and make sure that everybody knows that there's a Lollipop patient coming, and then attend the actual surgical team huddle as well, which will happen at 8:45. And then once that's happened and everyone's happy to go ahead with the patient, it will be probably myself and the research nurses to randomise the patient and to get that dispensing sheet and everything sorted. The plan, at least for the first few, is that it's going to be a different surgeons list, so I can purely be there from an from a PI point of view to make sure that runs smoothly.
Great, sounds good, thank you. And have you, so this wouldn't be something to think about from the offset, so while you're familiarising yourself with the trial, we probably wouldn't recommend having two Lollipop participants on the same list, but sort of once you're familiar with the trial, have you thought about the possibility of having two on the same list? Or do you think it's not possible? I
don't think it's going to happen, because most of our lists are half-day lists. There's only one that's a full day. So the only time that we would consider that when we're up and running would be, there's a Wednesday list that happens every other week that's morning and afternoon. So that's the only time that we would consider it. But the rest, no.
Yeah, that's fine. Thank you. And then, have you sort of had discussions with all the anaesthetists, surgeons, recovery nurses at your site? Are they all aware of the trial? And
absolutely, we've done a couple of training meetings. In fact, we've done one this morning, haven't we, Mandy? So everyone's on board. The theatre team are actually already aware of IV lidocaine because we've used it for different trials. So the recovery staff are very happy with that, actually.
Great, sounds great. Thank you. And then have you had a chance to use the test staging database, and do you have any questions around the database processes at all?
I don't, Mandy. Angela, do you have any questions?
No. I've had a test and I've printed out the anaesthetist spreadsheet so then they know what drugs, what vial we need to get and what drugs they can use. So I printed that out and we've shown the anaesthetist this morning that as well. No, I don't think there was anything. There was just one question that I read on, I don't know whether it was from the meeting yesterday, and it was about the anaesthetist cheat sheet. Is that something different to that spreadsheet, or is that what that means, or what? I just couldn't find that.
Yeah, so the cheat sheet is it's almost like an FAQ document for anaesthetists.
Oh, right, okay.
So yeah, we do send you a printed copy, I believe, but we can also email that over. Leah, I can't remember, is it on the website as well?
Yeah, it should be.
Yeah.
And CRFs, was it? What section on the? Oh, it's on the website, not the database. Okay.
Yeah.
Right. Okay. Okay.
So where, yeah, the website where the training is, there's a documents tab on that same website.
Okay, yeah, that's good. Thanks.
Okay. Any other questions at all about screening, consenting or randomising?
I'll just ask one more. So
Yeah.
when we randomise the patient, then there's some questionnaires. Do we do those questionnaires on the day of surgery?
They can be done anytime from consent, because obviously it's quite a busy time on the day.
Yeah,
So yes, so if it is easier to do them before, yeah, as long as they've
that was just
consented,
one question that I thought, could we do them before? So if we were, like, you know, because if we plan to see the patients probably face to face at pre-op, or when they come back to see the breast care nurses, because they normally have those two appointments, we could see them at either appointment, then we could do those questionnaires then prior to surgery. Yeah, okay, that's fine. Yeah, thank you.
I'll hand back to Mark now.
Thanks very much. Funnily enough, I am just been contacted by our team to remind me that I need to remotely prescribe for a lollipop patient this morning. So yeah, if I seem a bit distracted, it's that. Anyway, so when a patient's been randomised, or rather before you randomise, you put in the patient details, which includes height and weight, and essentially these things are used by the trial database to collect lean body weight, or to calculate lean body weight, which is the mainstay of the dosing of the lidocaine when the pump is being programmed. And the database will generate this very useful drug dispensing sheet, which is good to print out, take to team huddle, and is the sort of the paper trail for drug checking and administration. You'll see the sort of the details there. You'll see some numbers there which are a cross check when you're programming the pump. So when you do program the pump, put in lean body weight, and then you compare those numbers with what the pump has calculated it should give. If you're super eagle-eyed, occasionally you will see a 0.1 mil per hour discrepancy between this sheet and the pump for the bolus rate. That is, I think, just to do with the rounding of the calculations, slight difference between the database and the pump. I'm sure a quick bit of arithmetic will show you that is completely clinically negligible in terms of a difference. You're talking about probably less than 1 milliliter, much less than 1 milliliter of difference, because it's a 5 mil bolus. So it's just whether it goes in over 5 minutes and 1 second or 4 minutes and 59 seconds, basically, sort of thing. So please allow that to be the case, and you can sign off that difference. And then there's obviously checking. So there's checking at the point at which the vial comes out of wherever it's being stored, between the research staff member and one other person, who might be a second member of the research team, could be the anaesthetist in some cases, could be a pharmacy member, but essentially 2 qualified research team members checking that vial is correct and just matching it with the number on the sheet here. The second checking point is after pump programming. That's between the research team member and the anaesthetist, and the anaesthetist should sign off, so check that those numbers in those spaces there tally, and sign off along with the research staff member. The other thing that's very useful about this form is the blue box there shows you that it gives guidance on other local anaesthetics. So if you're wanting to use something for wound infiltration, or the anaesthetist is wanting to use something for a block, it gives you 3 different options. It's obvious, but I'll say it. It's either or, not all of those. They can't have all of those things all together. It's basically choose your local anaesthetic, and that is how much you'll be allowed to give. If you want to simplify things even further, the Australian team have provided us with a little Excel thing. If you're going into theatre with a laptop or something, you can basically put in the number of milligrams on the Excel thing and what local anaesthetic was, and it will give you milliliters of certain concentrations. So that's another way of doing it if you don't want to sort of calculate it there in theatre. But that's very useful, because you can use that as a point for discussion at the team brief, team huddle, to say whether other local anaesthetics can be used or not. Okay, any questions on that part of the process? Great. Okay, so next slide. So these are the main pumps that are going to be used for the intraoperative infusion, made by BD Alaris. A lot of the Australian training manuals are based on the slightly older model called the PK. They've just been updated to the Nexus PK, which is what BD are now producing. They work in effectively exactly the same way. These pumps that we provide you have been reprogrammed so it can only be used for LOLIPOP. So when you switch them on, you'll either be able to use them as a standard milliliters per hour simple pump, or it'll access the LOLIPOP program. So if you select the LOLIPOP program, put in the lean body weight, and it will then give you the numbers that you need to cross-check on that dispensing sheet. So just pause at that point. It won't alarm or beep. It'll just wait until you basically confirming then. So that's the point to you can load up the syringe, just wait until the anaesthetist is ready to double check it with you. And once that's done, you just press OK and confirm. And then it'll be on hold for the anaesthetist. They can join up, just attach the infusion. It's ready to go. In terms of working with the pump, obviously, we recommend the research team keeps it under their care rather than having it sort of just around in clinical areas. So just because it is just for the trial, very useful, as we heard on Wednesday, for it to be mounted. If the anaesthetist is using total intravenous anaesthesia, they might be using similar pumps. So just mount it below the anaesthetic pumps so that people aren't tempted to alter the rate or anything. In terms of managing the pumps, they've got a 3-year maintenance cycle. So hopefully, I mean, the clock only starts on that from the first usage. So it might be that you don't actually need to send it back to us for maintenance during the trial. If there is any problem with the pump, Southampton medical engineers will take care of that. So it's a case of couriering it back, and we can give you a replacement while it's being looked at. So hopefully no breaks in recruitment because of pump problems. Okay, any questions on the Alaris pumps? No, great stuff. Okay, let's move on then.
Thank you, Mark. So we're going to run through a bit of safety in the trial now. So this table you can see on the screen is provided in the protocol. We will also post out to you printed copies. It basically is a summary of the drug infusion stopping criteria at each sort of point in the patient's journey. So intraoperatively, in PACO recovery, and obviously you won't need to worry about the post-operative because you're not doing overnight cases. But yeah, just to say, a printout of this table should be kept with the patient at all times whilst the infusion's running. So that includes sort of in theatre and in recovery. So it's, whoever's looking after that patient at the time has clearly got this available to them. So the lidocaine infusion surveillance tool, or LIST as we call it, is this is a tool developed by the Australian team, and it's intended as a rapid aid to identify clinical symptoms or signs which may indicate the patient starting to develop lidocaine toxicity. And if they are, you would obviously stop the infusion. So the tool asks 5 symptom questions and looks for clinical signs, and you should start completing the LIST tool once the patient enters recovery, within 15 minutes of their arrival, or when you feel the patient is sort of awake enough to have a conversation with you. So for day case patients, you should ask the participant the 5 questions again once they meet the criteria for step down to reduce monitoring or discharge from recovery. If at any point the participant answers yes to 2 or more symptoms or has any sign or complication, you must stop the infusion. After you stop the infusion, if the patient is otherwise well and has stable vital signs, you should repeat the LIST tool hourly until all symptoms or signs have resolved or 2 hours have passed. If the patient is unstable, you should initiate rapid or urgent review by however it works at your site. So the anaesthetist, theatre emergency team, critical care team, and obviously make it clear to them that they are a LOLIPOP participant and have possibly had a lidocaine infusion, so could be experiencing lidocaine toxicity. If it is suspected lidocaine toxicity, you should follow the AA-GBI guidelines and unblind the participant. If intralipid is required, then don't wait for unblinding for this. Initiate that, given that intralipid whilst you're unblinding, and you can always stop if it's obviously not needed. all suspected lidocaine toxicity events are recorded on our CRF form 13, and you should report to the UK sponsor, so that's via the LOLIPOP mailbox, and enter in the form onto the database within 24 hours of this event happening. So I think the main sort of take home from this is if you stopping the infusion doesn't necessarily mean they've got lidocaine toxicity. So this tool is there to sort of identify the signs early and prevent, you know, emergencies happening basically. So if once you stop the infusion, the patient is sort of stable and well, you don't need to unblind that. That's all sort of resolved itself. It's only if the patient remains unstable that you should then go on to unblind. So is there any questions on using the list tool at all? And again, I can't see, so please shout out.
Oh, sorry, yeah. So I put my hand up. It's just a question really from the Met team. They said that if the patient is having like these reactions where there's 2 or more list symptoms, then obviously we're not going to unblind them until a severe lidocaine toxicity. But how do we, because they were concerned about not putting on the notes that the patient might have a potential lidocaine reaction. So they were just wanted that question answering.
Might have to ask Mark
Does
to
that-
enter that one,
Yeah,
please.
yeah. So are they, just so I understand their query properly, are they concerned that like nobody will know that the patient might have had lidocaine?
Yes. So say, for example, I mean, if they get called, then obviously we will unblind it. But they were concerned that if the patient has these 2 or more symptoms and we stop the infusion, but then the patient remains well, how do we identify or alert the notes that this patient might have a lidocaine toxicity if we don't know what they've had? Was their sort of like question?
Yeah, sure. I mean, I think this comes down to list being a bit non-specific and having a really low bar for stopping the infusion. We would not necessarily equate positivity on list with lidocaine toxicity. You wouldn't make a medical diagnosis of lidocaine toxicity based on the symptoms that could trigger list stoppage, if you like. I think it's important that everyone knows that the patients in the trial, so that they potentially might have received lidocaine, 50-50 chance, and that should be reflected in their hospital prescription. So, you should be using a hospital prescription which has a sort of either or format to it, so that it's clear that the patient might have been receiving lidocaine. Essentially, if the patients have got, what we find generally is when things are stopped, it's because of some of the symptoms, and they're all quite non-specific. I think that's the whole thing. It's non-specific, but it's just, as I say, just a low threshold for stopping it, because you don't want any slightly strange symptoms to persist and then develop into lidocaine toxicity. But I think it's really important to basically draw a distinction between the sort of minor symptoms you might have from the list tool and a medical diagnosis of lidocaine toxicity. So I think you should only really be wanting to unblind if there is severe symptoms that are very suggestive of toxicity. Does that answer your question?
Sorry, Mandy, are they thinking for the future? Are they thinking for further operations?
That's what they were thinking for, really. They were saying, like, how do we, that was just one of their concerns, that if there is like potential, I mean, I understand that these are low threshold and we don't want it, and then obviously if it is a medical diagnosis, but it's, if people have a reaction to antibiotics, sometimes they're documented. They were just concerned that how are we going to do it for future?
My view on this is that it doesn't necessarily need anything to be going on their notes to say. I think it's quite important not to. In fact, I think it's quite important not to try and give them some sort of label which might prevent them from having certain medications in the future. So there's nothing allergenic about lidocaine toxicity reactions. It's not, let's say somebody does have confirmed lidocaine toxicity. That wouldn't necessarily mean in the future the patient cannot have lidocaine. It might just mean that it needs to be given at a lower dose, or or their medications need to be different, or it needs to be used when they're less unwell, that sort of thing. It's not a thing where it's an allergy type situation. It's basically it's a dose response. So I think if somebody has had, even if they've had a definite reaction, sure, you'd note that probably in their medical history, but you would not necessarily want that label being put on that patient just because they had some slightly non-specific things after an anaesthetic that led to us stopping this trial infusion. I mean, if you go back and look at the list tool, I mean, some of this stuff we just see in recovery all the time. Can you just flick back? You will find there's some sort of grey area ones. You think, oh God, I mean, yeah, I mean, systolic blood pressure less than 90. I mean, usually not, but yeah, occasionally my patients will have, a single blood pressure reading of that in recovery. Fit and healthy patients sometimes, again, after an anaesthetic, if they're still nicely sort of comfortable and a bit sedated, they might well have, a slightly low respiratory rate or a slightly low heart rate just through the anaesthetic effects, actually. And if there's anything that's sort of, they might be waking up, might be feeling a bit sort of, oh yeah, maybe have got a funny taste in my mouth, and it's actually the anaesthetic. I mean, it's really non-specific stuff. So I wouldn't want somebody to be labeled as, oh, you can't have lidocaine in the future just because they have triggered positive on a couple of list things.
I'll try and explain that. Tam, you can help me.
Yeah, by all means, I can go and have a chat with them. And also, they can ask me about patients that have had their IV lidocaine infusion taken down. We can discuss it.
Yeah. Is that on a case by case?
If there's sort of particular concern being raised, we're very happy to chat with them as well. If they want to have a jump on a call at some point, I'm very happy to.
Yeah, that's great. Thank you.
Great. Any other questions around the list tool?
Not around the list tool. Sorry, Mandy. It was just, I possibly have a question really in terms of prescribing, and I don't know whether it really is you, Jodie, rather than the trials team, in terms of how we are going to prescribe it. Are we doing that online?
Do you normally use online in theatre, Tam? I'm not sure. I don't really cover surgery, so I don't know what. Do you normally have paper prescriptions?
We do have paper prescriptions in theatre, yeah, and the anaesthetists use paper prescriptions. I can do either. I'm just thinking about any remote prescribing.
We do normally the APMA for the patient, so it's online.
Okay.
Yeah.
Okay. Well, I mean, we can get that built for you online if that's what you want to do. Yeah.
For the IV infusions, we have the bupivacaine infusions for the rectal sheath catheters and for all that sort of stuff. So if we can have a LOLIPOP, the lidocaine infusion as a thing that can go in the EPMA from the pharmacy, I think that will be helpful for us to prescribe.
Yeah, I can try and sort that out for you. Yeah.
Great, thank you.
It sounds a bit like our system actually. So we obviously use paper anaesthetic charts. So anything has not got any implications for after the anaesthetic, we don't necessarily put we don't put propofol on an online system or anything like that. But anything that's got an implication for afterwards, so antibiotics, paracetamol, all the post-op analgesia, infusions of stuff, we always prescribe on our electronic system, and that's what we're doing with LOLIPOP as well. And it means that it really helps with the flexibility as well, because it means that I'm working from home today and I've just prescribed the trial infusion for 2 participants.
That's exactly what I was thinking of. Getting hold of people.
Yeah, no, absolutely. And because it's a CTIM, clinical trial of an investigation medicinal product, the prescriber does need to be on the delegation log. So they need to be trained up and on the delegation log. So Tam, I would definitely make sure you've got a mini team of people, and possibly get everyone on a WhatsApp group so you can sort of say, all right, patient this morning, who's able to prescribe, boom, get it done. And cross cover for days away and holiday and all that sort of stuff. And API is obviously brilliant to have one on board, and they can obviously chip in with checking eligibility and prescribing as well. And again, it just builds your flexibility if you can do that online.
Absolutely, thank you. Jodie, we'll link in together and sort that out.
Yeah, that's fine. Thanks.
Thanks.
Sorry, I just want one question about the list tool as well. So it's on section 4.3 on arrival to recovery, and then 4.4 is ward arrival. So where are we recording, 15 minutes before and before they leave recovery? Is it just those first two sections?
Yeah, so unfortunately that's a bit of a hangover with
Yeah.
so in Australia they were like doing all overnight cases until the UK sort of came on board. So it's sort of a bit of a hangover from that. So yeah, if you just use the first two sections as your one when they first arrive and then one when they're discharged from recovery.
That's great. And then say something they hit the two signs and then you're recording it like as per protocol because they've hit the two signs. Where do you document them?
I would double check this, so I'll put it in your SIV report, but I don't think you do. I don't. So I think you just record the two. I don't think you do the in between, but I will check my notes or confirm with the Australian team and get back to you about that
Yeah.
post SIV if that's okay.
Yeah, so it's because it says repeat the list tool hourly until
Yeah.
symptoms subside. So, I mean, we need to record that somewhere, don't we?
Yeah, I think it might be in a CRF. There's notes pages in the CRF. I think it covers it in there, and I'm just struggling to remember
Okay.
what I said. But I'll get back to you after the SIV if that's okay. Once I've checked everything.
Yeah, that's fine. Thank you.
I'm just writing a note for myself. Great, thank you. If no other questions, I will move on to blinding. So yeah, if you do need to unblind, so sort of examples of life-threatening problems where you might need to are sudden unexplained loss of consciousness, tonic-clonic seizure, life-threatening arrhythmia, and cardiovascular collapse. After randomization, you'll have the ability to unblind a participant on the database for 36 hours. So just to say, it's really important that if a participant's surgery date changes, that you make sure you go into the database and also update their surgery date on the database to allow you to unblind after the new surgery date. So everyone with an account on the database will be able to unblind, but also there's a generic unblinding login available to all sites that will allow anybody to go in and unblind a participant. So if a member of the research team weren't around for any reason, anybody looking after that patient can unblind if needed. So how that will work is the lead well, it's usually the lead research nurse will be sent, once you get access to the live database, you'll be sent a login for yourself and also a login for the unblinding, sorry, losing my words, the generic unblinding login. You'll then create a password for this and you'll write it on your unblinding guideline. So just a note that that password obviously will be written down and will be accessible by anyone, so don't make it a personal password. Will provide you with a printed unblinding guideline like you can see on the screen. So the quickest way to unblind is to scan that QR code and go through the generic login. So don't worry about using your own account in an emergency situation. You can just use the generic login via that QR code. If you do unblind a participant, you'll need to complete unblinding form 11 and also the suspected lidocaine toxicity form 13, please. And these are entered onto the database as soon as possible. Is there any questions about unblinding at all or anything in the unblinding module? Nope. I will go on to safety endpoints. So there are some safety endpoints listed in the protocol. These are documented sort of within the CRF if they happen. The infusion should be stopped if any of these events arouse cause for concern or cannot be resolved following treatment. So there's a bit of overlap with that table we showed you a few slides ago with this. And just to say that there's some of the events on this list are expected events, so they wouldn't require expedited reporting to the study sponsor unless the nature and severity of the event is inconsistent with the information about the drug in the RSI. So yeah, as I mentioned, they're recorded on the CRFs and safety reporting forms. So protocol breaches, so these are recorded on Form 10 of our CRFs, and those forms should be entered onto the LOLIPOP database. UK sites, unfortunately, do have a separate paper form that needs to be completed. So this is a UK sponsor requirement. So it's the protocol deviation assessment and report form, and that form will need to be emailed to the LOLIPOP trial mailbox and the sponsor safety inbox. If you do forget to fill in both, like, don't worry, if we have one, we'll remind you to complete the other one. So obviously, if you could try and remember, that's great, but if you don't, we'll remind you anyway. There's some examples of protocol breaches listed in the protocol, split into infusion related and non-infusion related. So you can see them on the screen there. So examples of infusion related ones are to inappropriate stopping of the infusion, or incorrect dosing of the study drug, failure to stop the infusion if the participant returns to theatre for reoperation. Examples of non-infusion related are open label administration of lidocaine in excess of the permitted amount. Just a point on that one is, if you do pick up that as happening, if it's before the trial infusion has begun, please don't start the infusion. If it's after the infusion's begun, then stop the infusion, because obviously we don't know if that participant is having lidocaine or not, and we don't want them to go on to then have the toxicity. And then, yeah, other examples are excessive dose of other local anaesthetic agents, and perhaps the patient being found to be ineligible after they've been randomised. And then also in the UK, any other deviation from the protocol obviously counts as a protocol breach, so they would need to be reported to us. So yeah, brief summary on safety reporting. So again, I won't go through all of these. You can look back over for your reference, but it's also in the protocol. But just to say, the summary of medicinal product characteristics for 2% and 10% lidocaine is the reference safety information for the trial. And yeah, the different forms for different event types there can be seen on the screen. So just to highlight that any SAE, SAR, SUSAR, SSI, or suspected severe lidocaine toxicity will need to be reported to us within 24 hours. You fill in the form, when you enter it onto the database, we'll get notified. So obviously you're welcome to email us as well, but you enter in the form onto the database within 24 hours, will notify us of that. So is there any questions about anything you've watched in the safety reporting modules at all?
I have a question. It's possibly for Mark, actually. In terms of, this is a question from our anaesthetists. So we have two main anaesthetists that do the breast list. They're both absolutely excellent, and they use permissive hypotension during surgery, which is wonderful for us because we get a bloodless field. But the question really was about intraoperative hypotension. So often our patients will be hypotensive, and in the literature it talks about hypotension during surgery, and if it's unresponsive to treatment, then we'd have to then consider stopping, but they wouldn't necessarily be treating that. So would it be okay to use that permissive hypotension if they're happy with the rest of the patient, or do we need to correct it?
Essentially, yeah. I mean, we're wanting to allow people to stop if there's something that is out of the ordinary. So if they've got something they don't like and they give some initial treatment for it, and it's not responding, that's the sort of thing that makes us think, oh, is there something funny going on with potentially some lidocaine here? Let's stop it. So if it feels normal for them and it's manageable, that's acceptable. I was just looking at the CRF actually on list tools and how certain things are treated in terms of safety endpoints intraoperatively as well. So we do record episodes of intraoperative hypotension. So particularly, so systolics of 80 or less are what we would count as an intraoperative hypotensive episode if it doesn't resolve despite treatment. Do you happen to know how low they tend to run them?
Yes, I do. So the anaesthetist works most closely with me. Sometimes the systolic's like 60, and he's happy with that. So 60, 70. So that's why it kind of flagged up to me that that would be much lower than what the trial's talking about.
Yeah. I think I might have to have a chat with them about it. It's, yeah, I don't want to say too much about the medical side of that. That's not fully mainstream, I think, these days. Intraoperative hypotension has become a lot less mainstream. There's a lot of data out there about prolonged periods of blood pressure less than 90 being bad for cardiac injury, renal injury, and so on. I recognise that, you know, it has been used a lot in plastics and so on to give favourable conditions, but 60 and 70s pretty low.
You know, yeah, I know. So perhaps it's worthwhile getting. Yeah, okay. We'll get both of them. Actually, I think it's best to give both of them a chat, because it's mainly the two anaesthetists that are working with us. One is more permissive than the other.
Yeah,
what I mean.
Yeah, sure. Let me just remember. Chloe, who is it? Is it Kareem? I'm hopefully having a chat with. What's Kareem's surname?
Kareem Mukhtar, yeah.
Yeah. So I think we're
yeah.
trying to have a bit of a chat just to go through things before we go live with you. I can find out if they're the sort of the more low blood pressure one or less. I mean, as I say, a bit of hypotension, yeah, fine. It's just, yeah, I need to have a think about that. So in terms of if they are on lidocaine, you know, and you're down at 60 or 70, there might be a point where you're thinking, okay, is the lidocaine contributing to this? If you're sort of targeting 60, 70, and then you did have a problem with lidocaine, you know, you might suddenly be at 50 or 60, which is, you know, really low. So perhaps something for me to have a chat about with Kareem, if that's okay.
Yeah, thank you.
But thanks for flagging it. That would definitely have brought up a query down the line.
Yeah, I would also have a chat with Kareem regarding the same.
Yeah, I think we've got a date, hopefully a date in the diary, either on the 9th, I think, or later in the month, for me to have a chat with Kareem about it anyway, because I was keen to kind of just make sure he was happy with everything and didn't have any sort of queries before we went live with you as well. So yeah, that's cool. I'm sure we can sort that out.
Okay, thank you. And then just a note for kind of a little quirk with the trial, I guess, and just sort of it being an international trial. It sort of, as the UK got some patients into the trial, and we started our data collection, the teams have realised that there's difference in dexamethasone doses or products used between Australia and the UK. So the UK used dexamethasone sodium phosphate, and Australia used dexamethasone phosphate. And these are reported slightly differently. So basically we are sticking with the Australian dosing reporting. So if 3.3 milligrams of dexamethasone sodium phosphate is used, you would document it as 4 grams of dexamethasone phosphate, and if 6.6 milligrams of the sodium phosphate is used, you'd document it as 8 grams of the dexamethasone phosphate. Again, if you do end up entering it in the UK dosing, that's fine. It'll be raised to you as a query on the database and ask you to update it. So yeah, that's just a bit of something to remember, but if you don't, it's not the end of the world. But this is sort of covered in the CRF manual as well, if you're using that as you fill in your CRFs for the first few participants. Yeah, I think that's all to say on that. I'm going to hand over to Leah now to go through some of the follow-up points.
Thank you.
So in Lollipop, we have 3 follow-up time points, 3 months, 6 months, and 12 months. So these are mainly by patient-reported questionnaires, and the way that we send these out is via a REDCap database, so they get emailed to participants. So hopefully that's really easy for them to like complete on their own time. If for any reason they don't want to complete these online, there is the option for you to offer to complete them over the phone with them. And in this case, instead of the reminders getting emailed to the participants, they'll get emailed to the research team, which is just like a handy reminder for you to call them. And then at 3 months and 12 months, there is a little bit of data collection from the medical notes as well. And that's entered onto the main database. So it's on a separate database, like all the patient reported stuff is collected on REDCap. If you're sort of not sure what data needs to be entered where, again, that is all detailed in the CRF manual. So it's probably quite handy for you to refer to that for your first few follow-ups, because we don't want you to sort of be duplicating any data entry. Like you don't need to be entering the patient reported questionnaires onto the main database, for example. We'll sort of move that across for you. And just a last thing to note, the 12-month follow-up is the where we collect the primary outcomes. So we do ask that even if for whatever reason the patient hasn't completed the 3 and 6 month questionnaires, that you still attempt to complete that 12-month one, unless of course they've like requested to stop. And we also have a sort of slightly longer time period in which to collect that. I think it's up to 15 months. Is that right, Chloe? Yeah. So you do have up to 15 months to collect that 12-month follow-up, because we just really want to make sure that that's done. Are there any questions on that at all, or on the content of the follow-up training module?
No, that's fine. Just on that follow-up training module, though, did I see something that said the trial centre will provide an Outlook email address?
Yeah, so basically that's to do with the REDCap reminders. So when just before the patient receives their sort of email to complete the questionnaire, you'll be asked to do a mortality check just on REDCap to allow that to get sent out. And we get those sent to sort of a group email. So that can either be, if you've already got a group research team email, we can use that. But if you don't have one, then we'll set one up for you. And that's what that's referring to.
Yeah, we don't have a group one.
Okay, that's fine.
Yeah,
we'll sort that out then. Yeah.
Yeah.
Thank
Okay.
you.
Thank you. And I just saw that there was obviously we're familiar with REDCap, but is there something called Mango?
Yeah, Mango is basically where we have the electronic delegation log. So that's a sort of separate one as well. I'll talk a bit about that at the end, but yeah, that's just literally for the delegation log part.
Yeah, thank you.
Thank you. Okay, next slide, please. Yeah, so we also just have this participant guidance document. So in the 3 and 12-month follow-up questionnaires, there are a few questions on patients calculating their total daily dose of pain relief medication, and we sort of recognise that might be a bit tricky. So we've developed this document which will be available when they're completing the questionnaires online. So there'll be a link to this document so they can work out how to do it, or if it's being done over the phone, you can either send a paper copy of this out to the patient, or you can email it over to them just in advance of their phone call, so they can have a look. Next slide, please. Okay, so just to sort of summarize that part then, we've just got a few like discussion points to run through. Obviously no pressure if you're not sure, we can go through it as well. So if a participant was randomized on the day of surgery, but then their surgery had to be postponed for whatever reason, what would your process be there?
would change the surgical date on the database.
Yeah.
So that we would have the unblinding. But with the vial, what would we do with that vial? I can't remember. Does
Yeah,
anybody else know? I don't know what with the number of that vial. Yeah.
Yeah, so we sort of recommend that you draw up that vial sort of kind of as close to the procedure as possible, because if you've already drawn that up and then something happens, then that would have to be discarded, and then the patient would have to discontinue in the trial because their allocated vial would have been used. Yeah, we don't have any kind of like spare vial system, unfortunately. So, but as long as that vial hasn't been opened yet, then you can just use that vial at a later date when they do come back for their surgery. So,
yeah, that's great. Thank you.
Just to add as well. Sorry, you might be about to do that, Leah.
yeah.
If the surgery has been postponed for more than 30 days, we would ask that you sort of recollect the baseline data and ask the patient if they are sort of happy to still continue in the trial.
Can I ask a quick question, please, about accountability? I know you said when I emailed you that you don't need to use the paper accountability logs. So when the research nurse randomises them and they get the kit, is that as much of the accountability as what you need? They don't need to go back in to the system. Just thinking if it got cancelled, there'd been nothing. Obviously, your system date would change for when it was given.
That's a good point. In terms of the surgery being postponed, I'll have to double check that. But yes, for a patient who proceeds, when you randomise, the system will automatically sort of allocate that vial to the participant and show that it's sort of left pharmacy or the research cupboard. But yeah, I will need to double check your point actually about it sort of going back in. I can't remember if that's in the pharmacy manual or not. So I'll double check that and get back to you if that's okay.
The pharmacy manual did show the accountability log, but it just said if it was just for use if the system failed. But if the system's failed, would they not have not been able to randomise it? I didn't really understand what the purpose of it was.
Yeah, that is a very good point.
Or do you want us to use paper do you want us to do accountability logs as well? I just wanted to double check, really.
Yeah, no, see, you don't need to use the paper log, but because it is all within the database, you know, you can add notes to that, you can move it to different locations. But yeah, I completely get your point about if the database is down, you can't randomize. So I guess it would probably be for like if you were moving, if the database was down and you moved it, like, you know, had to move the IMP on that day, it would be maybe for that rather than randomizing. But yeah, let me review that, and then if there's any points I'll raise it in your SIV report if that's okay.
That's fine, thank you.
Yeah.
And can I just ask as well, once we've used the vial, are we keeping the empty vial or are we getting rid of it?
No, you can get rid of it.
Just get rid of it. Okay. I just wondered, would it be a good idea if we did both paper and online, Jodie?
If you're happy to, because obviously you have to put it in the cupboard. Yeah, I mean, we normally do generally for pharmacy ones just as a backup.
Yeah. I think that maybe that we should do both, and then if one is back in the cupboard, at least on that paper we'll be able to document, won't we, that it's still in the cupboard for the patient ID number.
Yeah, as long as you're happy, I'm very happy with that.
Yeah.
Back to you, Lee.
Sorry, I was muted. Just move on to a bit of a recap on the safety part. So what would the process be if a participant had a seizure in the recovery area?
Sorry, it's a bit noisy where I am, but obviously we stopped the infusion, institute resuscitation and consider unblinding.
Yeah. And then just with unblinding, there's like a bit of paperwork to complete. So unblinding form. There would also be, you'd have to complete the suspected lidocaine toxicity form. Is it also an SAE form? Yeah, trying to think off the top of my head now. But
I'm sure Mandy will give me all the forms to complete.
Right, so what would the process be? So yeah, this is a bit of an unlikely one, but what would you do if the pump failed during the bolus infusion?
I think there was a bit of training on this, wasn't there?
Yeah.
If,
I was
I
going to
can't-
say you wouldn't give another bolus infusion, would you? You'd just go on to the next step.
Yeah,
Would you?
that's right. You just
Yeah.
go onto the mils per hour function.
Yeah, that's right. The one exception is if it's giving the bolus and you get a brief occlusion alarm. Sometimes if the pressure in the line gets a bit high, you'll get a little occlusion alarm. If it's something simple like the line's just been kinked or the cannula needs a flush, that's fine. You can carry on from there. But yeah, if the pump completely blacks out for whatever reason, you're quite right. You need to make sure it doesn't try to restart a bolus. But then basically what happens if when you reboot the pump, you just choose the mils per hour option and use the mils per hour rate that's from the dispensing sheet.
Great, thank you. And just last question, what would your local process be if a participant wasn't or hadn't responded to their 1-year follow-up questionnaire?
Because this is the main outcome for the trial, we would, if they hadn't reported it or hadn't filled in the questionnaires on the database, then maybe follow up with a phone call with them to see if we can help them. And if they hadn't done it on the database during the phone call, we can change the database to do it over the phone with them, and then we can complete it over the phone with them.
Yeah, exactly. Thank you. Right, next slide. Thank you. Yeah, so this is just a note on recording all your training and everything. So sounds like you've already kind of had a look at the training on the website and probably seen this training log, but we've just got kind of a bit of a guide on what sort of who needs to complete what module. And then after today, now you've had your SIV, you can record all of that on your training log. So there's a link there or QR code, but it's also on the website. And you can just, record what you've done. Once you've done that, you can also complete your delegation log. And as I said before, we are doing this on a system called Mango. You might already have an account with Mango if you work on any other Bristol Trial Centre studies, but if not, you can sign up, and once you've registered, you'll then sort of be asked what studies you want to add, and you can add LOLIPOP to your account and then complete your delegation log. Just a note on that. So every sort of member of staff will be approved by us first and then approved by the PI. So the PI will need to sort of register as well. And we'll approve their account, and then it's good if the PI can kind of select all the delegation log tasks just to sort of represent that they'll have oversight all of those over those. So that was just kind of a reminder that to the PI to check when everyone's registered and go on and improve those accounts. So next slide, please.
Sorry, Leah, can I just jump in? Just to say, I can't remember if following your feasibility meeting, we sent you the anaesthetist and recovery nurse training slide set. So just to say that not every anaesthetist, for example, needs to be on the delegation log. If they're simply the attending anaesthetist on a LOLIPOP case, they don't necessarily need to be on the delegation log. They just need to complete some brief training from a slide set that we are very happy to provide to you. And then they just sort of sign off that, or the PI will sign off that they've done their training. If they are going to get sort of more involved in the research and I don't know, for example, sign off eligibility or maybe involved in approaching patients or anything like that, then they will need to be on the delegation log. So yeah, just to flag that. Have we sent you those slides?
Is it just like a short video, is it?
So
Because
it's
Victoria
a slide
from Victoria from the Royal, she
yeah.
sent me two. She sent me a longer one, the one that I've watched, and then a shorter one. Or is it slides?
It's slides, and then there is a video within the slide set.
Oh, right. Then no, we haven't got that.
Okay,
And then, because that leads on to my question that I had for the end, was just to confirm who needs GCP. So if we have obviously our key people that have got GCP, and then there might be a theatre operational manager that has it as well, and one of the recovery nurses. So not all the recovery nurses need GCP, do they?
No.
No. Okay, that's it.
Yeah, so if they're sort of not doing anything above and beyond their everyday role, so for example, if so recovery nurses can eventually do the list with the patient. So we don't advise that to begin with. We would say, research team to do that while everyone's getting familiar. But eventually they can do the list, but that, it would be, we kind of see it as part of their routine observations kind of thing. So they're not sort of doing anything above and beyond their everyday role.
That was our plan. So obviously we've delivered the teaching to them this morning and prior to it, just to get them all familiarised with. But there's a lead recovery nurse who is willing to do a GCP. So for the first, so many patients that we will be doing it with them, and then obviously then the other staff will be doing it as part of their role.
Yeah, sounds good.
Thank you.
Okay. Sounds like you're already aware of this, but we just wanted to note that we're registered on the Associate PI scheme. So happy for anyone interested to sign up for that. Yeah. Sorry, Mark's got his hand up, so we'll just.
Yeah, just on the APIs. We're just moving on to our second API at Southampton. They've been absolutely brilliant. Really, contribute to the trial. I think it's been a really good education for them. So, Vina, I hope you have a good experience. I'm sure you will. There's a bit more there used to be not that much flexibility in like the timing and stuff. Obviously, need Vina to sort of get a 6-month period so she can get signed off for everything. If you've got more people interested, in theory, they only really want, or it always used to be the case that they only want one API at any one time from one single specialty. And I think that's probably a reasonable concept, just in terms of the amount of mentoring time you've got and them getting unique opportunities to contribute and get things signed off. But they are quite flexible. So for example, if somebody's coming along in the 6 months towards the end of Vina's time, and there's a bit of overlap time, they're basically fine to have, a bit of overlap time where you've perhaps got Vina handing stuff over and the new API getting up to speed, that sort of thing. I think you can have a second concurrent API from a different specialty as well. So if there's anyone surgical that wants to get on board, and they might have a slightly different approach on how they get those things signed off. But yeah, it's a really nice trial to have an API on for sure.
We've taken advantage of that, Mark, actually.
Say again, sorry.
We've taken advantage of that, Mark, because after the initial meeting that we very first had with you, we've got Nidhi on, who's just turned her camera on there. She's poorly at the moment. She's joining us from home. So she's from a surgical side of things, and then Vina's from the anaesthetic side. So I think it'll be really helpful having the two sides working together with me.
Yeah, that's brilliant. Really good.
Great. Yeah. So it's sort of coming to the end now, and I usually just go through this site initiation checklist we have. I'll just share it on my screen. So yeah, this is just it'll just give us an idea of where we're at, really, sort of what needs doing. So obviously we've received the feasibility form from you. So PI, CV and GCP certificates. So when you register on Mango, when everyone registers on Mango, there'll be an option for you to upload that. So that is sort of covered there. Protocol agreement. I'm trying to think back because we've got quite a lot of sites in setup, but I have a feeling you may have sent this over.
Yeah, so I think we have, Tam has signed the PI protocol agreement and we have signed that. So we have done that. Yeah.
Nice. And then training logs. So that, again, you'll sort of complete that after today. So that's, yeah, that'll be in progress, and sort of same thing with Mango. Is there any update on where we are with sort of getting the contract ready, things like that?
Yeah, I'll speak to R&D about that today and then say that we've had the site initiation. Can they move forward with that? So yeah, I'll sort that out today.
Yeah, sounds good.
It'll be soon. Because we've got Jodie, our clinical trials pharmacist, isn't here next week, so we won't be able to receive any IMP. And obviously we can't open, can we, until Karim has had a chat with Mark. So we'll get that in process before then.
A few things to fall in place.
Yeah.
Great. So ISF checklist. So I think we've probably sent this over, but it's just so you don't need to sort of create. We don't specify whether you need a paper or an electronic ISF. It's whichever sort of you prefer to do locally. But we just ask you to complete an ISF checklist for our records and send anything over that we need to sort of make our own copy of that, basically. But I'm sure Chloe's already sent that over to you. Right, I'll tick that one off around the site initiation visit. So it sounds like you've got the study drug storage all sorted. Yeah,
we've got a space. We're just waiting for a lock. So we're going to keep the study drug that's going to be temperature monitored remotely by the pharmacy team, and the pump in one cupboard.
Okay, great. So we will send the pump out to you as well, sort of once that contract's in motion. So that will come soon. I think we've already mentioned, it sounds like a few of you have had a look at the staging database, but is there anyone who's sort of missing access to that needs it?
Don't think so. I know me and Tam have had a go. Angela's got access to it, and our data manager, she's on annual leave, but she's obviously started getting all things in process. So she'll obviously need access to Mango and the database. I think she's
What about Vina and Nidhi? Do they need access?
The associate PIs.
Sort of up to you, really. Depends how much they'll be doing on the database, if they need to sort of have a play with it for training purposes, really.
I suspect they won't be doing a massive amount on the actual database. It'd be more the
we didn't. Well, I don't think we bothered getting our APIs database access. I guess the only thing is if they wanted to sort of have a go at randomizing, but we mostly got them focusing on sort of eligibility checks, scribing, and then also sort of shadowing the sort of the approaching, the consenting, so they can get some experience of recruiting the patients.
Yes, that's fine. Then we don't need that. Thank you.
Great. And just have you got some 50ml syringes available that will fit in the Alaris pump? Yeah.
Loads.
They'll all fit. Yeah, they'll all fit. It's not. There's some stuff about Terumos, but that's just for the post-op pumps. Any 50 will fit in the Alaris, and they'll accept them.
And do you have some intralipid available in the theatre and recovery areas?
Yeah.
You've already provided the localization details to us, and we're in the process of sorting those out for you. So we'll send those over when they're done. I think it sounds like you've seen the CRFs, so you've got a copy of those. ISF setup, I guess, is in progress. So pharmacy site file, that's just whether you've got everything you need for that. There's like a contents page that we can provide and things.
Yeah, I've just downloaded it from your website and that,
Great, thank you. You've already raised awareness of the trial within the relevant teams and done a bit of training, so that's great. And the last thing we have on the checklist is just for everyone to kind of have a go at like running a patient through the trial, like on the database, which, yeah. Okay. And that's everything. The rest is just to do with sites who are doing overnight cases. And then there's just a few things to be done after green light as well. But yeah. So it looks like we're making good progress.
Great, thank you. So yeah, I won't reshare the slides because the last slide is just our contact details, and we'll send you a copy of those slides anyway, so you'll have those. Before I ask for any last questions, could I just confirm from you which hospital you're going to be recruiting from, or is it a mix? Or like,
Yeah, this
just...
is always a bit of a thing because we have just merged. So the actual trust is Mersey and West Lancashire Trust, which has got 2 main sites. One is Southport and one is Wiston. But we will be recruiting from just St Helens Hospital, but it comes under the name of Wiston Hospital. But it's always a bit of a...
Okay. So in terms of the database, what
Yeah.
would you put it? Because yeah, the Australian team like to put a hospital name on the database. So what you tell us? What's the
St Helens? Let's
Helens.
use St Helens Hospital. Yeah.
Okay.
Yeah.
Southport don't do any breast cases. So.
Great, thank you. Okay. Yeah, that was all from us today. Is there any questions from you guys at all?
I think we've covered everything that we needed to cover, didn't we, Mandy?
You provide the patient ID cards, don't you?
Yes.
Yeah. And then we just write on them the study ID, do we?
Yeah.
Yeah.
One thing actually, you might have got this from the videos, but just to highlight that you don't actually get a study ID number for a patient until they're randomized. So obviously, if you want to use your own perhaps like screening number or something so you can track them before they randomize, you're welcome to do so. It's just make sure from the point of randomization or once you've got that randomization study ID number, you use that going forward. But if it helps for you to have your own numbers before that, you are very welcome to. Because I know in the UK we'd usually have one before randomization. So just wanted to highlight that.
And the drugs, the IMP will be delivered to Jodie at the Wiston site to check in, and then we'll transfer them to the St Helens site. That's the plan, isn't it, Jodie? Just want to confirm that. And then all other consumables will be coming to me at the St Helens site. Yeah.
Great.
So the unblinding account, just to go over that, the one that everyone can access, that'll come to me and I'll pick the passwords for that. Yeah.
Yeah. Okay. And then you can just write it on your sheet and then anyone can log in and
yeah. Yeah, I think that's all my questions, but I'll email you if you've got any more.
Yeah, no problem. Thank you very much. So yeah, after this call, we'll sort of send you an SIV report with any outstanding actions highlighted, and then obviously once all those actions have been completed, we can look to green light you. So yeah, all that's left to say is thank you all for your time today, and we look forward to getting you open.
Thank you. I have got one more question. Sorry, while I was looking through my notes. They talk about some stickers for notes, but we don't have those for day cases, or do we?
So we will provide you. So Annie, our administrator, actually, as we speak, is putting you together a startup pack, and there are some stickers included in there. So yeah, so when you get that pack, if you have a look what's in there, and if there's anything sort of missing, let us know. But it should all come to you in the post.
Right. Okay. Okay, that's great. Thank you.
No problem. Great. If there's no more, thank you everybody, and hope you have a nice weekend.
Thank you.
Thank you.
It's a
Thank you.
match.
Thank you.
Thank
Bye.
you. Bye.
Bye.
Bye. Bye.